My name is Demilade. I'm a PhD student from the State Laboratory of Marine Pollutions, City University of Hong Kong. I'll be giving us an update on our recently conducted review on the levels of pharmaceuticals in estuary systems and also the environmental risk assessment. So I welcome you again to the GEM workshop. So we all know that pharmaceuticals are contaminants of global concern and priority.
Hello, excuse me. Hello, we cannot hear you online. Can you check your microphone?
Okay.
Thank you.
Now, okay, you can hear me now.
Hello?
Yeah, I can hear you, but I cannot hear Demi. It's Demi, right?
Hello?
Can you put your microphone closer?
Hello?
Yeah, now it's good. Yeah, thank you.
Okay, perfect. Thank you.
Perfect.
All right, so as we all know, pharmaceuticals are emerging contaminants of global concern and priority. And as population is increasing over the years, we also see that there's we also see that there's increase in drug production, sales, and use, and there's direct influence on the discharge of these pharmaceuticals to the environment. Hence, there's need to study the status of these pharmaceuticals in the environment. So, several studies have reported several diverse adverse effects of pharmaceuticals, including antibiotic resistance in wild geese. Antibiotics was also reported in drinking water as far back as 2006 and recently in 2024 in geese. Knowing all of these adverse effects, there is urgent need to assess the levels of these pharmaceuticals in global estuaries. So this tickled our curiosity, and we had a number of logical research questions. We want to know, are these pharmaceuticals actually widespread? What are the type of pharmaceuticals? Are they actually of concern and priority? Where are they? What region? What country? And which parts and which country has the highest pollution levels? We also want to know the ecological and environmental risks of these pharmaceuticals, if there's any. And we want to know if there's a relationship between the levels of these pharmaceuticals and the socio-economic peculiarities of each region. Eventually, we want to know all the wide knowledge gaps. So in our review, we comprehensively collected data and simulated to know the levels of pharmaceutical contamination. We also were able to, using this review, to highlight the pharmaceuticals and type of classes of pharmaceuticals of concern. And we also evaluated the ecological risks, and we carried out a correlation analysis. So, for our method, we were able to access two wide databases, Web of Science and Google Scholar, over 2 decades, 2003 to 2022. And we collected a total of 72 studies, arriving to 239 pharmaceuticals over 91 estuaries. Because there are differences in the summary statistics reported in each studies, and this will make it very difficult to compare studies from different regions. Different studies have used different type of method, different type of sampling methods. And because of this disparity, we introduced the model, the weighted average concentration level, which will help us to also input data like the detection frequency, the number of times of samplings, the season of sampling, and the likes. So for the ecological risk assessments, we collected data in knowledge databases like ECOSA and ECOTOX under the US EPA, and we collected the toxicity value, PNEC value from reported and published articles. Overall, more than 267 estuaries are currently identified globally, and a very large percentage of them has not been studied yet. So in this review, we collected data in 91 estuaries over the 6 continents: Africa, Asia, Europe, North America, South America, and Oceania. So because of time, we only presented the data on the top 20 pharmaceuticals in all of these continents. So we have the top 20 pharmaceuticals, and the last column for each of them indicates the other pharmaceuticals that are present. So yeah, looking at it, that red dotted line, that's like from the 100 nanogram per liter. It shows that Africa has the highest weighted average concentration levels compared to other continents. So in Africa, the purple box indicates analgesic, popularly known as painkillers. The example is paracetamol. And the light green indicates antibiotics. So in Africa, we noted that the highest weighted average concentration level was observed in salicylic acid, which is a painkiller, also called analgesic. And the blue one is for antiretroviral drugs, which is used for treatment of HIV/AIDS. And it was closely followed in Africa in lamivudine. And a problem in Africa is that it's one of the top countries with the highest load of antiretroviral, anti-HIV/AIDS viral load. And that must have accounted for why there's high level of lamivudine, which is the drug also. So to Asia, we noticed that the highest weighted average concentration level was observed in caffeine, just like my boss recently said, which caffeine has been in consumption for a very long time in Asia, and a lot of painkillers also. So for Europe, we observed a wide range of different pharmaceutical classes, including painkillers, antibiotics, antidiabetic drugs, bronchodilators, which is used for treating asthma, and we also have the lipid regulator, also used for treating fat issues. So in Europe, we had 7 out of the 20 top pharmaceuticals reported as painkillers. And another observable problem in Europe is we observed a very high, relatively high concentration in tramadol, this particular one. And that's because Europe has one of the highest GDP consumption rates for opioid analgesic, and tramadol tops the list. So for North America, we observed that the highest was reported in metformin, and it was reported in USA. And we also have a number of painkillers and antibiotic drugs. For Oceania, very unique one, we noticed that almost 86% of the top 20 pharmaceuticals were antibiotics, the green boxes. And we had only few classes of painkillers. Another notable thing about Oceania is they are very limited data. So this might not really account for a good comparison in Oceania. And finally, South America, the same thing was almost close to Asia. Highest was observed in stimulant, caffeine. So we carried out the ecological risk assessments for the 239 pharmaceuticals, but we were only able to collect toxicity data for 209 out of the 239. So we observed that a larger percentage of all of these pharmaceuticals are still within the range, the red box, below H hazard quotient of 1, and also a total of about 40 pharmaceuticals above 1, and a total of 19 pharmaceuticals above the hazard quotient of 10. That's prone to very high ecological risks to the environment. And I also want to state that diclofenac, a very popular painkiller, has hazard quotient of 10 in all of the continents. That's a very point of concern. So we carried out a correlation analysis. We tried to compare the weighted average concentration levels of these pharmaceuticals with the socioeconomic factors. So we identified some factors like the poverty ratio, the GDP per capita income, life expectancy, population size, death rate, unemployment ratio, and age dependency. But we observed a very good correlation in poverty ratio, GDP and unemployment rate. So I presented data for these ones. We notice that there's this blue line going upward shows the positive correlation between poverty ratio and weighted average concentration levels and unemployment ratio with weighted average concentration levels. That means in country that is high poverty rate, there's possibility that there will be high levels of pharmaceuticals, and this can be linked with the insufficient weight and sewage treatment plans in this country. Also, there's very limited medical facilities. So most of the population actually access the pharmaceuticals over counter. The more you buy them, the more you consume and disperse to the environment. Also for the GDP, we can closely relate the same reasons to the poverty ratio. So when I started, I presented some logical research questions. So after all of these processes, are we able to actually answer these research questions? At the end, we now know that pharmaceuticals are actually widespread and of concern in global storage. We had about 230 to 235 pharmaceuticals that were detected, 40 pharmaceuticals with high risks with hazard quotients of greater than 1. Antibiotics and painkillers were the most frequently reported globally. Paracetamol and diclofenac, which are painkillers, and carbamazepine, which is an anti-epilepsy drug used for treating epilepsy, were all the 3 that were reported globally in all of the continents. However, there are a lot of limitations in this study. Like we all know, we collected the studies in different continents and countries. And most of the studies have used different methods, different sampling methods. These pharmaceuticals were in different exposure durations, some even sampled in 2 different seasons. This is a very serious problem in making a comparison for this data. So this study may be limited in that aspect. So, and this is one of the reasons we now have GEM, which will help us to establish a standard protocol. So now when we sample globally, we can now use the same method and the same standard. And this is going to give us a reasonable level and a leverage of comparison for this study. Thank you very much. I want to share my work. My immediate boss statistician, all of the GEMs and our colleagues and our members back home in SPLMP, and also CCU Safety Lab and ITC for all the funding. Thank you very much.
Okay, thank you, Demi. So we will still have time for 1 or 2 quick questions. So please.
Very much. Very happy.
Sorry, maybe close to.
Thank you very much for your presentation. It was very apt, short to the point, and very well summarized. I have 2 questions and probably 1 contribution. What I would like to see from this global network. The first thing is you explained all the differences as to why there were variants in the pharmaceuticals found in the different areas. What I want to ask is, in Europe, at least, there's the everywhere generally, there's a wave now, personalized medicine. Okay, and with personalized medicine, painkillers, even if you can buy them over the counter, okay? And if we're finding that in the estuaries with personalized medicine, the only medication, so to speak, that they put a measure not to be sold over the counter is antibiotics in Europe. Okay, so how we're still going to see pharmaceuticals in wastewater with personalized medicine. So with your research, how are we going to navigate that problem of personalized medicine? If I go serious, what changes or what expectations do we have now that they've introduced the personalized medicine? Okay. There's something that there are a lot of factors that actually influence the levels of pharmaceuticals. One of them is exposure duration. So the fact that there's now a ban or a closed way or a restriction to accessing this pharmaceutical doesn't mean we won't find them again. It does not mean that painkillers will not be in the estuaries again. So we expect that if there's a reduction in consumption over the years, if I do the same review or we do the same review in 10 years, maybe in Europe we'll have the lesser level for painkillers. but it doesn't mean we will not find them in the estuaries.
So the question is, with personalized medicine, what it's doing now is, over my phone, I have my digital doctor.
Okay, so you can access
I
them
have
easily.
access, so the thing of access in Africa, for instance, you just go online. With personalized medicine, access to these medications also become
Easier, of course.
because now in Europe, if you go to the hospital, your GP sends your prescription to the pharmacy, which is regulated, and with that, there's that restriction. But with personalized medicine, you know, we're still going to see more of this. So my question is, with your research, which is something that's very profound, how can we get this result to the policymakers who and the
How can we get it to policy makers?
yeah,
Okay.
to be able to show these other signs of negative effect of personalized medicine?
Okay, there's a point where we share data also in our steps. When we conduct our research, it doesn't stop there. We publish them into articles, and people like my boss in top areas also they share data, and they also talk to top people in advisory boards for each continent. So it's through these meetings and advisory meetings and positions that we actually get our data to get to all these points. So we hope that in some of the places they can actually influence the policy making. Thank you. Is that it?